The transcription is very effective.
Okay, we are live streaming and now we're recording as well.
Thank you.
And that will let attendees in, and let's see who's coming in.
Good evening, friends.
Good evening, friend.
Good evening.
Hey, who's that? Oh, it's Robert. Hey, good to see you.
Okay, Ray.
You have several board members in the attendees list already.
Great. Okay, so if everyone can put their screens on mute, and we're going to start. Welcome, everybody. We're so glad you're here. My name is Catherine DeLazaro, and I am the co-chair of Health and Human Services alongside Sheldon Fine. When we come together as a community, it's important that every one of us contributes to this being a safe, inclusive, and supportive environment for everyone. So before we start tonight's forum, I'm going to describe some rules and guidelines for participation and civility. First, I'm going to share some relevant sections of the bylaws. And I want to thank Susan Schwartz, the chair of the Bylaws Committee, for providing us with this information. Article 1 of the bylaws calls on board members to treat others with respect and courtesy. Members are expected to treat other board members, members of the community, and representatives of agencies, elected officials, and all others with respect and courtesy while acting in their capacity as board members. Article 5 of the bylaws notes that the chairperson presiding over a board of committee meeting shall have over a board or committee meeting shall have the discretion to remove a member, a committee member, or a member of the public from the meeting if the member is disruptive to the functioning of the meeting. In no case shall a chairperson, however, prospectively prohibit an individual from attending a board or committee meeting. So those are the bylaws. In terms of the guidelines for tonight's meeting, we encourage everyone to listen to each other in order to understand and learn. Please focus your questions and comments on the topic of tonight's discussion and in response to what the speakers share. Attendees' comments in the chat will be visible to panelists only. So when the members of the public post in chat, comments will only be available to the panelists. Please sign up to speak in the Google form. We will let you know if there's a time limit depending on the number who sign up. And we're going to ask that everybody who wants to speak sign up through the sheet. That includes committee members and board members. And Rosa will explain that. But we're going to ask everyone to sign up on the Google form that Courtney has generously agreed to post in the chat regularly. We are community, so let's please communicate in ways that are respectful, collegial, and professional, and as much as possible in ways that assume goodwill. This means we focus on addressing issues or asking questions, not making any personal attacks, bullying, or slandering individuals by name. It's inappropriate to speak in ways that are derogatory or negative towards whole groups, and we respect and encourage diversity of perspective and opinion. Comments are most effective and easiest to understand when people speak from their own experience rather than claiming to speak for all people in the community. Please use your legal name in the chat and sign up sheet. It's necessary for every participant to follow these guidelines in order to maintain a space that's inclusive, welcoming, and safe for everyone. No one will be interrupted or removed as they speak unless they're acting in ways that compromise these guidelines of civility. We don't expect that to happen tonight. It's going to be a fantastic conversation, and we're so glad you're with us, and we want to hear from everyone. So on that note, I'm going to hand it over to Sheldon Fine, the co-chair of Health and Human Services.
You're muted. Okay, I'll start over. Do it better. We're very blessed, the Health and Human Services Committee, to have many very talented, intelligent, and experienced members who bring a lot to the table and make our committee really a wonderful experience for the committee members, and we try for the community. One such member is Rosa Arenas. Rosa has taken her passion about the issue of racial and economic disparity and turned it into a forum with outstanding presenters. It took her hundreds of hours, I believe, because just from what I know and from the number of emails, the number of Zoom calls with presenters, the number of texts, the conversations. I don't know how she is getting away with it because she works too. She has an important job, but she's done an amazing job. And she's done it because of her passion and also the need for our community to be educated and have a deeper understanding of this issue from the people who study this issue and are engaged with this issue professionally and in the community. So it's my honor to introduce our host for the evening, Rosa Arenas. And I'm sure, I think ahead of time, we should thank her for this wonderful effort that she put together.
Hey everyone, my name is Rosa Arenas. I'm a member of the Health and Human Services Committee for CB7. I'm just going to start out quickly. I know Dr. Fullilove has to go pretty quickly. So the protocol for our discussion is each speaker will take about 10 to 15 minutes. After everyone finished, we will then take questions in response from the committee, the board members, and the public. Today, we're going to take questions from committee members right after each speaker. The first two to sign up in the interest of time and in consideration of the speaker's time, and questions from board members and the public after all the speakers speak. Everyone must sign up. Please just try to ask one question at a time. So first up, we have Dr. Robert Fullilove, who is the Associate Dean for Community and Minority Affairs, Professor of Clinical Socio-Medical Sciences, and the co-director of the city's research group. Dr. Fullilove.
Thank you. So let me just make clear, this is a teaching night for me.
That's right. I forgot about that. Yes, he has a class at 7:30, so he has to go first.
Indeed. So let me just say that this may be the 9th of the set of town halls that I've been a part of, where people have addressed the all-important question of where are we with COVID-19 and what are we doing about vaccines and vaccinations? Over the course of the last month, I've observed that these town hall meetings have had an increasingly interesting tenor that went from, oh my God, I'm really doubtful about whether or not I should do this. Are the vaccines safe? They were developed based on a project that had the name of all things, Warp Speed. Did that mean that they just threw things together, didn't take their time, and created a product that maybe is not safe for me or for anybody who takes it? That set of issues and questions gradually evolved. The vaccine rollout has done a number of things. Number one, large numbers of people all over the country and thousands here in New York City have been vaccinated. It's been very clear we don't have people dropping dead in the street as a consequence of complications from this vaccine. Although I'm really happy to answer any one of a variety of questions about the nature of the vaccine, how it was developed, why people like me in public health are so confident that it has what it takes to help us slow down the pandemic. I'm also aware of the fact that in the last 3 of these that I've done, people are already pretty clear. It's not a question of if I should take the vaccine. They want to know, where do I have to go?
Who do I have to bribe? Where do I have to find a phone number, email address, anything that'll get me to this? And it's also the case that as folks like me who have had the vaccine are able to sort of say, look at the great shape I'm in many respects, that's probably the most important factor that I think can come from me as I try to help you think through some of the issues that this campaign and COVID-19 has raised for all of us. First and foremost, I don't think I look it, but I was born in 1944. I just had my 77th birthday. I've had both versions of the Pfizer vaccine. My most recent dose, the second dose, was February 10th. No after effects, no problems. I'm still walking, I'm still talking. And if anything, I think for a guy who's pushing 80, I look pretty good. Second point, I was a part since April of a number of efforts on the part of the National Institutes of Allergies and Infectious Diseases to oversee the clinical trials that put this set of vaccines together. I'm talking specifically about the Pfizer vaccine and the Moderna, because those are the ones that are currently being distributed. And I was very clear that in a panel that included representatives from 5 of the major communities that are most impacted by COVID-19, the folk who were responsible for doing the clinical trials did an excellent job of pulling together random samples of individuals from each of the impacted communities that were not only well balanced with respect to age, socioeconomic status, and risk status, meaning were you in a situation where you were likely to be exposed to the vaccine. The results that they got, 95% efficiency, has to rank as some of the most effective work that has ever been done in vaccine science to produce something that is quite this good. It wasn't rushed. It wasn't rushed. We have been dealing with SARS-CoV viruses for a good period of time now, since 2003. A substantial amount of work had gone in to understand what's the nature of coronaviruses, what are the things that are most likely to impact the ways in which an effective immune response can be mounted, and what can be done with this new technology, messenger RNA, which will not only revolutionize the way we produce vaccines in the future, it has all kinds of possibilities for a wide variety of illnesses where altering the DNA and the RNA of some infectious agent might have a really important element that will help us prevent a whole host of diseases that have haunted humankind since our arrival on this planet. I'm very clear that here in Washington Heights, we really struggled with issues of making sure that the people who deserve the vaccine and the folks who should be vaccinated first have found access. Of all the things that I think has accompanied the rollout of the vaccine, the inequitable distribution of opportunities to be vaccinated has not only deviled us here in New York City, I think it's been a problem all over the United States. Those of you who, for example, read newspapers from all over the USA may have seen an LA Times article this morning that talked about all the folk who managed to bump the line to get what could be described as early and semi-illegal access to the kinds of tickets that get the vaccine distributed. I think that that says something that's very important. People have switched from being doubtful about the efficacy of the vaccine. We're now in a situation where everybody wants to get it. And it seems to me the most important thing that a forum like this can help us produce is to come up with effective ways of making sure that those who are most in need of access to a vaccine will get it and get it in a timely fashion. I think that that's a top priority. One final thing, and then I'll stop. I want everybody to be clear that the vaccine does not convey what we call preventive immunity. It doesn't completely eliminate the possibility that if you're exposed to COVID-19, SARS-CoV-2, that you won't become infected. What we are clear is that it dramatically reduces the likelihood that you'll be hospitalized or that you'll die. So what we're really trying to do is get to a situation where most folk who are exposed to this virus will get something that feels very much like the common cold or a bad case of flu. Trust me, with all of the folk that are here at the medical center struggling to do what they can to meet all the demands that have been created by this pandemic, the most important thing we can do is preserve our medical care staff and our hospital capabilities. I worry most about the fact that the way we're dealing with this pandemic is to make sure that people have access to a doctor and to a hospital. Ladies and gentlemen, that's not sustainable. Doctors are wearing out. Hospitals are finding that they're really taxed to the maximum. People who have other healthcare conditions that require some kind of regular access to medical care are now finding that that has been made that much more difficult because we're so engaged with dealing with the pandemic. The most important thing about what can happen is that if we get vaccinated, we have to continue to practice all of the issues that we know are important to keep ourselves safe. You got to continue to wear a mask and you got to practice social distancing, even if you've been vaccinated. It's a hard pill to swallow, but I have a real sense that we are just about to see the light at the end of the tunnel. My hope that that light isn't because it's a train. Let me stop there.
So I think we're going to take some questions. I'm going to ask for assistance from Catherine and Shelley.
And just a reminder,
Ooh.
Oh, Catherine, you muted yourself.
thanks. Sorry, even members of the public and committee members and board members should all sign up on the sheet if they want to speak.
I'll ask a question. Okay, I'll start. First of all, I saw you on New York One the other night, and was or Cheryl Wills, I made a program possibly, or on the news, and you were, as tonight, fantastic and clear and right on point. Regarding the effective ways to get people most in need vaccinated, all the data says that that's not happening, no matter what's happened so far. Is there anything else you can think that the city, the government can do to change that around, okay, to make that happen? Because they seem to be setting things up here and there, and I don't see any real great change. Okay.
Yeah, I've been hearing the same thing, nothing but problems. I live right across the street from the Armory, where Columbia Presbyterian is doing the bulk of its work to provide people with vaccines. And what I'm seeing there look much more like patients of the hospital than residents of Washington Heights. So a number of us have been urging the city to do their best to go through agencies like community-based organizations that are already dealing with health, and especially through you guys, through the community boards. You have a lot more connection to the people in need than folk in the hospital do. And I just want you to know, I'm not an employee of the city. You might have noticed that Columbia is a private institution, so I'm not a public worker. But I have been trying to lean on the people in the Department of Health and in Health and Human Hospitals to make sure that we do something to make sure that the current barriers to getting appointments and getting some ability to get to the place where the vaccines occur has been made available. I know that there are a number of community groups that are trying to do that. And I'm thinking that one of the people that I've been working with has been someone in Gail Brewer's office. I hope mentioning a political name isn't a problem here. But I am trying to think that if you can't get the bureaucracies of the city to do something, maybe this is the time to call on the politicians to say we really do need to make sure that that what we have is an equitable system of vaccine distribution, because it's not working. And I agree that it's really, at this point, something of a shame that the people who are most in need are not getting the things that they need. So I agree with you. It's something that is really not working, and it's got to be improved. Otherwise, I think we're going to have a real disaster on our hands.
Hey, thank you. Yeah.
And thank you for letting me know that I was on TV. They filmed that at the beginning of Black History Month. Was that what it was?
Well, it was on the other night, and I
my
said,
goodness.
"Oh, there he is." I said,
Thank you for that. I owe you guys. I'm already in your debt. Thank you.
Yeah,
Yes,
okay.
please. I see a lot of hands up.
Madge and Robert, maybe. could you-
Robert was actually first.
Yeah,
We have
Robert
Rob.
had his hand up for a
Okay.
while.
Good.
Mon cher ami,
Rob-
vous avez un nom français. Je vois bien.
So Robert, and then Helen, and then Madge, and then we also have a member of the public, and we should probably stop after that. But if everybody
Hey,
could
Doc-
please,
Doctor,
Sign up.
you mentioned that it's not, Doctor, you mentioned that it's not, Doctor,
If everybody to sign up on the sign up sheet, that'd be easier to manage. Thanks.
Doctor, you mentioned that the vaccines are not that they're not preventative, but what is my term, the mitigation quotient with respect to the new variants that seem to be coming in? We're getting reports of more being identified in the city each day. So that means I have a better chance because I had my 2 shots. Now I'm getting really confident to go out to have dinner. And am I better off now with these new variants or what?
Drive a little fast.
It's like your job.
Yeah, that's your job. You know, make up that lost time on the track.
Let's
That's not
mute.
me. Hi.
Did you hear my question, Doctor?
Yeah, yes, I did. I wanted to say
I
that.
don't know what that was about. Yeah.
No, it's okay. It's okay. The new variants really represent what happens when you have long-standing reservoirs of infection that aren't being treated or touched. Viruses mutate. The classic example is HIV, the virus that causes AIDS. That mutates every 1.9 days. These coronaviruses don't mutate that quickly, but they've got an entire planet at their disposal and whole populations that are getting almost nothing. So they are changing. What we don't do in the United States is what they do in France and in other countries in Europe, where with each effort, they try their best to test the genetic variation of whatever virus somebody is infected with. We're not doing that. As far as I can tell, we've only been able to assess the genetic types of coronavirus that we have in this country with less than 2% of all the samples that are available. So we are suspecting, because it's happening in England, it's happening in France, in a variety of other countries in Europe, that the variants are becoming more and more powerful. It's not entirely clear whether the Pfizer or the Moderna are going to be effective against the 2 most common types, the one that comes from England and the one that comes from South Africa. There is some sense that it does convey some immune protection, but it's not a cure. What we're trying to do is create an effective response on the part of the immune system so that instead of getting deathly ill, folk our age will only become sick. That is to say, sick in a way that doesn't require hospitalization or a lot of discomfort or even a lot of disability. I do believe that no matter what happens, after the second dose, you are mounting an immune response. And there is some hope that your immune system is learning what it has to do whenever it sees something that looks like a coronavirus. That's the hope. But that's why I insisted that you can't assume that we're going to vaccinate ourselves out of this pandemic. We are not. We will be safe because people continue to practice social distancing and they continue to wear masks, especially when they're indoors. I believe that the drops that we've been seeing in infection rates are much more likely a result of what we've been doing about successfully getting the general public to behave than they are because we have vaccine rollouts that have suddenly produced a wave of herd immunity. That has not happened yet. So people have to continue to be cautious. It's really been hard. I know I hate it. You see what I got here? I've been here 11 months. I can't stand it. But I'm also pretty clear at my age, I can't afford to go dancing in the street. And I'm hoping that other folk will agree that at least for the time being, until the all clear is sound, vaccines plus masks plus social distancing. That's what's going to help.
Thank you.
Wow,
Good
you're
question. Thank you.
amazing. You're amazing, Dr. Fulov. But I was really interested when you said that doctors and the and medical professionals are, I think you said, I don't remember your exact words, but it sounds like exhausted. You've all just been working super hard because this has been overwhelming, and that you've tried to raise the alarm to the city. Could you talk just a minute more about that and what you see coming down the road and what the city or hospitals could be doing?
I think more than anything else, what I'm seeing is that in the communities that are hardest hit by this pandemic, much of what we're doing to make sure that people get the vaccine is ask them to go online using their smartphones or their computers. There is such a thing in the United States as the digital divide. There are a lot of people who are in their 70s and 80s who don't have access to computers because they don't have a 10-year-old grandson who is able to come in and do all that stuff. And as a consequence, making sure that you have access because you also are able to effectively use modern technology is putting a huge burden on the population that I believe to be most at risk. So what we've been urging people to do is figure out, how do you get rid of the digital divide? What do you have to do to make sure that if access to care is going to be monitored via your computer or via a smartphone, that there are community centers where people can go where that can be done for you? If we're trying to keep track by making sure that there is an electronic digital record of somebody requesting to be vaccinated, if we can't get it to simply be a case where you walk to your drugstore the way you used to get the flu vaccine every year, if we're in a system that has become so complicated it requires a computer to do, how about we make sure that all the community-based organizations and all the community boards like you guys are in a position to provide that kind of service, especially for the folk who don't have access to that level of technology. I think the technological divide is the thing that worries me most, because of all the ways to manage a pandemic, this has got to be amongst the worst.
Thank you.
And yeah, just a point about folks being exhausted. Is everybody clear? This is not sustainable. You know, the whole notion that the way we're managing this pandemic is to say, you'll go to a doctor and you'll have access to a hospital bed. Well, I am somebody who had congestive heart failure about 15 years ago. I have to see a cardiologist on a regular basis just to make sure that my slim, trim, boyish looks are maintained. And the whole notion that everybody is bound up dealing with COVID-19 means, excuse me, when do I get my turn? People who are dealing with other chronic diseases from diabetes to cancer are suddenly discovering that now it's all telemedicine or being told to wait. The real toll that this pandemic is going to take is not going to be on the folk who are infected with COVID-19. It's all the other folk with chronic disease conditions who are unable to get access to the health care that they need because we're too bound up in taking care of this pandemic. We've got to take it off the shoulders of the medical profession and start pushing back to deal with some of the problems that are created. And may I say it, because this is what I've been doing in the prisons and jails. Do you understand that, you know, of all the places, of the 17 places that have the highest concentration of COVID-19 in the United States, 16 of those are prisons?
Sure.
Infections in prisons make their way out into the general community. We've already been clear that at least 7 to 10% burden of infectious disease in cities that have jails comes from the fact that every single week, you probably have in the United States, 700,000 people who are locked up in a jail. They'll be there for a week. 54% of them are going to be released. They've been in a congregate setting where they're packed and jammed together, creating the perfect conditions for the transmission of this virus. And as long as we think that prisoners, inmates, don't deserve to be vaccinated, we're making sure that that pool of infection that I talked about earlier, that has for too long a time gone untreated, will continue to be a source of variants, and it continue to be a source of infection as prison staff leave their jobs, go back home, and carry with them a virus that they probably got while they were doing their jobs on the inside. It really is going to take a kind of a radical rethinking of how we do health in this country, because asking doctors and hospitals to carry the burden, we've already seen 11 months into this pandemic, is not working, and we're using that supply up rapidly.
Thank you.
Thank you.
Dr. Fullilove, it's almost 7:30, so I imagine you have to leave, but thank you
indeed.
very much. We're very grateful for your presence.
Invite me back sometime when I'm not teaching. I'd love to speak about this stuff more. Clearly, I don't have a problem talking, and I like the questions, and I would love to do this again.
Okay,
Thanks
thank you
again.
so
Much
much.
appreciated.
We'd love to have you.
Thanks.
Okay. So we're very fortunate to have a great relationship for many years with Mount Sinai Health System, and especially with Brad Korn, who's the corporate director of community affairs for the whole system. And he is with us tonight. He's in the center of my screen. I don't know where he is in other screens. But he's also brought two outstanding, high-level and talented. Brad, would you like to say hello?
Sure, you were doing such a good job, Shelley. I was just going to let you do it. So,
okay. Well, would you want to introduce?
I want to thank Dr. LaPassion and Pamela Apper for being with us tonight.
Okay, so he has arranged for us to have two just high-level and outstanding people Dr. Vicky Lopachin. She's a Senior Vice President, Chief Medical Officer for the Mount Sinai Health System. And Pamela Abner, who I heard of, because she's highly regarded in the area of diversity, not only locally, but around the country. And she's Vice President and Chief Diversity Officer for the Mount Sinai Health System. I think a few years ago, Mount Sinai was considered #1. It's always been in the top few, but #1 in diversity issues rated across the country. So we are honored to have them here tonight. And do we have the speakers? I don't see them on my screen.
We're here.
Okay, so who would like to begin?
We're here.
Hi, Pamela.
Hi, everyone. No, thank you so much for having both of us. That's a little bit of a tough act to follow, I must say, in full transparency. That was a fantastic talk, and I really enjoyed it myself. So Pam and I chose to speak a little bit to the group about how we at Mount Sinai Hospital, our health system, are really advancing quality of care with a focus on equity. And, you know, as an institution, we've been committed to achieving the absolute highest quality of care and safety. And we know that in order to improve quality, right, we need to understand all the aspects of things that go into our outcomes. And that's going to include, if you really dig down, that's going to include what is the impact of racism and healthcare disparities on our quality outcomes and on the outcomes of our patients. So, you know, we've been doing this work for a while. I mean, as you pointed out, Mount Sinai, we've had Pam with us. We've had a good Office of Diversity and Inclusion. So we clearly have understood that this is important. But a lot of things happened last year that really brought us to the place where we needed to really do this work much quicker, right? So we had the pandemic. Everyone saw the disproportionate burden among the racial and ethnic minorities, how it affected our patients, but how it affected our staff and how it affected our staff's families. And then there were all of the incidences with the political upheaval, racial injustice. All this sort of culminated at a time where we were looking to revamp one of the mechanisms in our health system for doing this quality work. So prior to the pandemic, we had a mechanism, it was a group of people, of leadership, and it was called the Quality Leadership Council. And this was really a very robust group. It's led by myself. And we have all the hospital leadership from each one of our health system hospitals, as well as leaders from quality, leaders from safety, you know, HR, marketing, IT, data analytics. And this group would routinely come together every 2 weeks, and we would have a presentation about quality. We would look at data. We would talk about, you know, how to do quality improvement. All that got put on hold during the pandemic, right? All these normal meetings, you know, we were completely, you know, consumed with caring for the pandemic patients for, you know, a big chunk of time last year. And so when Pam and I and a few others got together and we think, okay, we're going to restart this, and really took a hard look of the work that really needed to be done. How do we really, like I said, fast track and do this at a much faster pace, really being sure that we incorporate quality, health disparities, equity into our quality work. So a couple of things we did, we brought this group back together. We openly discussed how this was now going to be a dialogue that we all needed to learn. We all needed to do this better. We needed to look at how we were using our data, how we were collecting our data, how we were incorporating the data, how we were analyzing the data to drive this work. And so we created a subgroup, office committee, a little work group. With the goals to really increase the number of people of color that worked in our quality and safety leadership roles. We revised our mission statement. We really wanted to create an environment where our leaders could have a safe space and openly speak in open conversation and learn from each other. We wanted to look at how, again, like how we collected our data analytics, how we were going to use that going forward to drive this improvement. And we started with some very simple steps. We started with a good old-fashioned book club, and we committed to this, I think, at the end of the summer. we started with white fragility. We then went to, so you want to talk about race. And our last book that we just completed was The Death Gap, How Inequity Kills. And I think this book in particular really helped our membership put together and connect all the dots between racism, health disparity, and how that was affecting quality. And then at every meeting, we have, a regular presentation. We started to look at how race and ethnicity is affecting the quality metrics that we're talking about, how we're going to drive that into our performance improvement. And we're just creating open small group discussions around these books so that our leaders can just openly learn from each other. And that's something that I think is a little unique for a healthcare organization of our size. So I'm going to actually ask Pam to chime in a little bit, and she's done a tremendous amount of this work with me, and she's just a fantastic partner.
Well, thank you, Vicki. And I just want to say to everyone that I don't even know if I can express how much Vicki and her leadership and others, we've come together around really addressing structural racism, naming it, number one, naming it for the organization, and then advancing our work specifically to address it. So, and that is also parallel to efforts that we have within Mount Sinai Health System, that we've formed a task force to address racism. So that was happening at the same time. So there's a concerted effort, again, with healthcare leaders across the system to look at all the tentacles of structural racism and how that impacts every aspect of our medical care, medical education, how we interact with one another. So we spent the majority of the last 6, 7, 8 months focusing on that. As it relates to quality work in patients, as Dr. Lopation noted, even just getting our leaders together to learn together. So, and I will say this with, all due respect to our leaders, but the vast majority of the leadership who were in this quality audience were white, right? So white individuals who make a lot of decisions that impact the lives of people from many communities that are not all white, right? So we knew that, right? So again, we had to look at ourselves and say, what is this? What are we doing, right? Who's making these decisions and what's in their heads, right? So we knew that a lot of these leaders didn't have any experience or exposure or understanding of the depth and the harm that structural racism then produced in our communities, right? So one, we spent a lot of time with that. Again, and I applaud Dr. Lopation because she took that on. She and I had a lot of very serious, frank conversations about that and developed a wonderful relationship around this topic, and we continue to do that. We also then said we need to bring other people to the table in terms of who those people are who get to make these decisions. So again, a concerted effort that we made to promote and intentionally, that's one of my favorite words as through this process, is that we intentionally put Black leaders into positions of power, very high level. Vicki's team, and for instance, she just hired a senior Black physician as a quality lead for the system, right? So we said we're gonna start to show up and do the things that we're talking about. So we promoted a number of Black leaders in our organization who can be at the table, make decisions, and be part of our efforts to instill an anti-racist culture and dismantle these structures of racism. So that's something that, and it's a continue, as you all know, this is not going to happen overnight. It's a continuum. It's something that we're working on. We're working on together, and we will continue to do that. So the other thing that really supported our efforts as it relates to, again, looking at quality outcomes in patients and data. And data, as you know, is also very important, right? We have to look at what's going on with our patients. So some of the work, it's not all, but some of the, one of the many kind of areas of focus that we look at, and some of the work that I lead has to do with our patient data collection. So I can say, fortunately, probably back in 2016 or 15, again, I came to work with Vicki and other leaders of our institution on patient data collection, right? What does that mean? How are we capturing specific information about patients, their demographics, their background, race, ethnicity, LGBT status, language, things of that nature. So we had that work starting, and I will just share very briefly when, I kind of bumped into it by accident, but it was fortuitous in terms of how the situation really wasn't one where the institution at large was paying attention to how we capture that information for our patients, right? Especially in terms of race ethnicity data. So we spent the last several years honing in on that, working with our staff, understanding how they were being trained or not to collect information from patients. We've held a lot of focus groups, worked with patients, brought them in actually to hear the patient's voice, and helped us really develop a way to address bettering the way that we capture information. And I'm really sparing you some of the misery and the stories and the pain that I went through to get us where we are today. But just to know that there were lots of gaps in terms of we just didn't have data on patients because it was not made a priority. So fortunately, again, that's years and years of work in terms of capturing information correctly, letting people self-report, not have people kind of look at someone and guess, well, they might be Latino, they might be whatever, just by looking at them. And those were practices that existed. Again, part of that, the things that we wanted to dismantle, those behaviors where people were not treating our patients in a way that they needed to be respected in terms of how they interacted. And also getting rid of the fear and mitigating the fear that our patients had in terms of even why are you asking me these questions? Why do you need to know about my background? But we needed that background information so that we'd be better poised as we are today to look at differences in care. So when, with the advent of COVID, when we needed to look at data, we were well prepared to do so. So what we did, again, in the same audience of our Quality Leadership Council, we were able to look at data based on not only the patient's race, ethnicity, but bringing in a lot of other factors, right? Social determinants, where they lived, and other factors. And then we relied on our data scientists, right? So because we have a medical school, as you all know, we were able to bring in expertise around really taking that data. And we brought in someone who's beyond fabulous in that regard, to a Black researcher, Dr. Emma Benz, I'll give her due respect and call her name out, who came in and really helped the same body of individuals to understand how to look at data, how to use race data in terms of assumptions and planning, so that things were being done, appropriately, right? So the data wasn't being misinterpreted or used in a way that wasn't appropriate for our patients. So we continue to do that. My team continues to work across the system to work with frontline staff, administrators in terms of how we collect information. We're continually modifying as we need to any of our systems, the education materials. Again, we continue to work with our patients as well and have discussions with them in terms of their level of comfort. And this journey will continue for us. And I think that we've created a foundation through this Quality Leadership Council. It's just one example of the work that Mount Sinai is doing, and our leaders are committed to that. And I think it's really putting us in a good position to be prepared for whatever comes around next and what we have to do, and bringing all that together for a system. So I'll stop there. And if anyone has any questions, we'd be happy to answer them.
Sure.
We just want to remind everyone that you should be signing up, even if you are a board member. We're requesting that everybody sign up so we can, and here's the link, it was just put in the chat, so we can make sure we get everyone's questions. We're trying to keep it to a minimum of 2 right after the speakers, and then we'll have time for extra questions at the end. Does anyone have a question for the last 2 speakers? If you have
Catherine signed up.
I didn't sign up, but I'll be glad to ask a question.
I think Catherine signed up. Catherine?
I did sign up, and I think Helen had a comment as well. So my question has to do with access to care in the hospital, based on the kind of entitlements or benefits people have. So what I've heard is that hospitals in New York and elsewhere can be segregated, in part because of how much hospitals are willing to take, and providers within the system are willing to take Medicaid and insurance in the New York State exchange. And so I was wondering if you could speak to what the requirements are as far as accepting Medicaid, Medicare, and then also insurance in the exchange. And if you've thought of how you've kind of addressed economic access for patients that don't have private insurance, not just in hospitals, but also among your providers.
Vicki, you want to take the first part? I'll take the second part.
Wait, go back to the first part. So, it's one of the things that we know that exists in healthcare in general, right? We do make a commitment to provide care to everyone, regardless of insurer, payment status, et cetera. But, we are starting to look a little bit more closely and focusing on the where, right? So we're going to take care of everybody, but we need to look at where they're cared for and ensure that we have equity in the services provided and the access to services provided. So I think that's really the work that we're taking on and dealing with. Pam, you wanna add in here?
Yeah.
Vicki, let me just add for 1 second that we are clearly a safety net hospital and we take care of people regardless of ability to pay.
Right.
Also, we have a strong history of that as Mount Sinai and as the predecessor of Continuum who joined with Mount Sinai. They both have a strong history of that.
Right. And so the second part, thanks, Brad, but the second part of your question, I think, also touches on a sensitive topic as well in terms of the where and how. So one of the things that we are addressing, I referenced earlier that we have a task force to address racism within the organization. And we know that there are differences in terms of Medicaid patients versus private patients. So we do have a strategy to address that. So, and that's something that we've been talking a lot about, unification practices, and that's top of mind and part of the work that we will be addressing going forward.
I have a question, but the chat is too small for me to see. And then when I finally did get that link, it just took too much time. So I don't know if I can still ask.
So go ahead.
It's a comment, really. And that, and it's great that it's Mount Sinai that we're talking to, because the answer is in the precept and the concept of what we still call, the initials are not used, but they're called FQHCs. These are the comprehensive community-based health centers. And the one that was formed in the early 70s in East Harlem is called Boriken Neighborhood Health Center. I'm part of the origination board of that center, and it's still one of the finest ones. And the planning team was the Department of Community Medicine at Mount Sinai, Dr. Juan Bosch. And part of the idea, the concept of FQHCs is the care that no one can be turned away, because the reimbursement pattern for the health center based on efficiency, they become the recipients of federal grants out of the Bureau of Primary Health Care, which can amount to, if you're really an efficient center, say, I'm talking the site in 1970s, it could be quite more and different now. $700,000 a year, if you really, and that's the encouragement to run your center really well. In other words, you demonstrate to the government how efficient you are in signing up people for Medicaid, and then how efficient you are in collecting on a sliding fee scale. No one is ever turned away. And that whether that can mean the sliding fee scale can mean $5 for a visit. And if you're making $80,000 a year, maybe it's $50 a visit, okay? But what I'm getting at is the concept is there. So we're not at the point of having to reinvent the wheel, because it's integral to the idea of the FQHC. The ones that we're familiar with up here is one of the flagships, and it's always been a high performer, which is the Ryan Health Center. It's an FQHC, and it's a national system. So there are thousands of them across the nation, in all of the populations, and all of the people of color populations, and Native Americans, and the Puerto Rican communities that we're considered the Northeast, and in the African American communities in different parts, and the Native American, I think I mentioned, and so on. But they're all over the place. And so the affordability factor is not the issue. Okay, so that's not what we're looking for, new research in there. The barriers with the system that is in place have been lowered and knocked down by the entire movement of the 60s, okay? And the healthcare is there, the access is there. And with the pandemic is a different issue, because the pandemic is the persuasion factor. And whether you're poor or wealthy or upper class, middle class, do you take vaccines? Maybe you don't take vaccines because the polio vaccine syndrome, okay? Where most Americans would take it, but how many do not? And then you have movements against vaccines, people, based on whatever. But with respect to the presentations from Mount Sinai on the algorithms for data collection and the whole thing, the job is being done by the providers that exist, and they're being done quite efficiently. So if I sound like I'm a defender of FQHCs, it's in the blood, it's in my DNA, because I'm part of the origination of that.
Thank you, Robert. I think we're Helen, did you have something to say, council member? No? Okay, so we're gonna move on, I think.
Okay, I just
Sorry,
want
I
to,
muted myself.
I
Sorry.
just wanted to say one thing.
Yes.
I think it's extraordinary what the Quality Leadership Council has done. In education, we're doing the same thing in terms, a couple of the same books, in fact, because people feel that they're comfortable in their own lives with their attitudes and their experience. And all of a sudden, it goes deeper and you hear from different voices, and it makes such a difference over time. What I'm wondering is, how does that filter down to your employees? Okay, do they have these discussions? Do they have seminars? Do they have conferences to discuss these issues?
Yeah, absolutely, Shelley. So it's not just that it's within QLC, right? So we were speaking specifically of that group, but this this work that we've been doing is across the system. So the same, starting with white fragility is one. We've worked that through each of the individual hospital presidents, right? Their leadership teams. I've actually done sessions with all of them. And then we continue to do sessions and talks and all types of forums. It's not just around white fragility, but other things. And we've created, now we have a couple of different forums. One is a chat for change that emanates from our medical school, open to everyone, right? So people get on, they can log on to a Zoom conversation, and we have really provocative, intentionally, and sessions where people can share and learn together. We also host other forums as well. So it's ongoing. It's ongoing. We're rolling out now something called Brave Conversations, working with managers, supervisors, and others to get them to start talking about these matters of race in particular and structural racism. And we are continuing to do that. And I don't see that ending at anytime soon. But this is becoming part of the norm, right? We expect our leaders to have conversations with their staff. I particularly worry about our frontline staff, right? The vast majority of whom are Black and brown individuals, and that those who supervise them understand who they are. And it's not just go have a meeting and have a conversation. It's really getting people to understand the perspectives of others and then understand the harm. And Dr. Ansel says this in his book, The Death Gap, the structural violence that occurs in our systems, right? Between poverty, race, and location or zip code. And he kind of defines that as structural violence, contributing to the disproportionate death or disparities that occur in our societies. So we are very much into involving the entire community in those discussions. It's not held just for our leadership group.
Okay, great. Thank you, Brad, Vicki, and Pam. This has been so valuable.
Thank you.
Thank you for all the work you do, great work you do.
Thank you
for having us.
I actually have one quick question for Ms. Abner. I'm sorry. How do you account for patients of color? Do they have a say in this? Like, do they have a way to,
good question.
Is there a survey system or something that allows them to speak up when they feel they've been targeted in any way?
Yeah, so we do have a process that patients, we have, actually, Vicki, do you want to answer this? Because I don't want to take away from your answering if you want.
No, go ahead.
Yes, so we do have a means. We do have a patient patient experience and patient reps who are throughout the organization. We also have reporting mechanisms, and we encourage staff to report incidents with patients, and we have ways for patients to report into us as well. So we do want to hear their voice. Patient experience, for one, as patients are discharged, they do receive those questionnaires or surveys to fill out. And we look at that information. I was just actually, I could talk forever on this, and I don't want to do that. But I was just looking at that information the other day. So again, we brought in that lens of, let's look at the outcomes by race as one factor, right? So we started to do that. And we're cleaning up that information and data, but we've seen some very interesting outcomes and perceptions, right? In the way those questions are posed to our patients, where whites, just might see their healthcare in one way, and we notice varying differences between our racial groups. But yes, we do get that information. And if there's something that's a grievance, that's part of the process that has to be addressed right away. But we are getting patient experience data, and we work on that regularly, looking at that regularly.
Thank you very much.
Sure. So thank you for having us again.
Thank you for being here. I guess we'll be moving on to the next group. I think you all have to go, but thank you so much for being here. We look forward to working with you again, hopefully
Sure,
soon.
please, anytime. Thank you very much.
Rosa, can I ask a quick question?
Sure.
I'm curious, taking two people, one of color and one not, who are patients who have access to care at Mount Sinai, are there differences between the ways that they are treated by staff in terms of treatment, in terms of tolerance of pain, in terms of expectations? Is there some kind of unconscious racism that where the staff treat different people of different races differently?
I'll answer that this way. I think that that's part of human nature, right? So people have biases. Again, we could spend a lot of time here, and I don't want to take up all of your time. Biases exist in all humans and all individuals, and we know that it exists in medical care. So to answer your question, just off the top of my, yes, of course there are differences. Are they intentional? No. Are there things that people do that they're not aware of? Possibly. Yes. So we spend a lot of time also in educating our teams or bringing forward the notion of being aware of your biases. How does that get in the way? How biases contribute to disparities in care? Pain management, there's tons of studies that have been done on that, right? The New York Times, I think in 2019, had a whole series of how Blacks were treated as it relates to pain management. So that happens. We know that happens. And would that happen at Mount Sinai? Well, we're part of a larger system. So of course that can happen. But do we address it? Do we bring that to the forefront? Do we talk about that? Do we talk about that in our medical curricula as we teach our medical students? Absolutely. But it's there because biases exist in humans. But we do work towards eliminating those biases. That's part of our race bias initiative.
Thank you.
I'm sorry, I do just have a really quick comment.
Sure.
I didn't realize y'all were having to leave. You're not able to stay?
There is a purpose in this.
No, we have to leave at 8 o'clock.
Yeah.
You have to leave at 8. Oh, okay. Well, thank you for being here. I just was really interested about the meetings that you're having going up, with the president of the hospital, with board members. I'm interested to know if they're focused on this. And the reason I ask is because I recently co-chaired a hearing where the Greater New York Hospital Association seemed to indicate that the presidents of hospitals, it was hard to get their attention on these matters. And while, people like Pam, like you, Vicki, and certainly the medical students are trying to sort this all out. Just wondering what you thought of those meetings, sort of, looking up the chain of command.
So and Pam can chime in as well, but I have to say for the group that I lead, all the hospital presidents are part of that group. As well as I do report outs to the Committee on Quality, which is our subset of our Board of Trustees. And we have a tremendous amount of commitment from executive leadership. I also have Board of Trustee members who do serve on my Quality Leadership Council, and they've been going through all of these learnings with us. They've been doing the book readings with us. And Pam, maybe you can also talk about the executive task force, which does include our dean and our health system CEO.
Right, thank you. So even before that, our Office for Diversity reports into our CEO. So he commissioned and sanctioned our work and gives us, if I may say it this way, we're charged to do this work. So, and likewise on the medical school. So we our dean of the medical school, and then the task force that I mentioned, the task force to address racism, again is commissioned by our CEO and our dean of the medical school. So you can't, within the context of the organization, that's a senior committee, and they are aware of what we're doing. All the roadmap, as we call it, and the strategies and interventions. Absolutely, they've reviewed them, and they work with us and support us wholeheartedly through this.
That's great. And Pam, I really loved hearing about your data collection work. Mm-hmm. And I hope there will be transparency around the results of that, and that that data will be publicly, the analytics on it will be publicly reported.
Right now, thank you. Right now, we're using it, internally to address some, where we want to focus on certain patient experience areas, or where we think we might have concerns within the organization, certain populations or divisions. But yes, we use that information, to guide us in many ways in terms of the work we do with our patients.
But it won't be reported publicly ever, or is that in the future?
That I just can't answer because I'm not sure what, if there's, I know that there's research that happens and that comes from our school, so that data will be used to inform research, absolutely. So to the extent that that's published, yes, you will see that it's the same race ethnicity data because we brought all of our systems together. So our researchers are using the same data that we've kind of standardized across the system.
Thank you.
You're welcome.
All right, thank you very much.
Okay, have a good evening. Thank you.
Thank you. Up next, we have Dr. Ushma Neal, who is the Vice President for Scientific and Education Training at Memorial Sloan Kettering Cancer Center, and her team is working on vaccine info pointed at high school aged students. Dr. Neal?
Thank you, Rosa, and everyone else. Helen, I just wanted to mention, like, the president of MSK, the diversity office reports directly to him. They're fully involved in all of these different things. And to your second question, unless you have institutional review board approval for publishing patient level data, if it's collected, it can't be published. So if they aren't super transparent, it might just be because when they collected the data, they didn't do it with forward thinking towards publication.
So thank you, Dr.
Yeah, little question, a little answer there. So coming from a cancer center, one of my primary interests is the HPV vaccine, which is an amazing vaccine that's very safe and took over 25 years to come to market after full safety data, and is an amazing anti-cancer vaccine. And I am one of the people leading the charge around HPV vaccination in the community and even within our institution, and have, in that regard, faced a lot of social media hatred from people who are anti-vaxxers and have a bit of experience in this realm. It tends to be more from the ladies who think lavender oil would work rather than years of mistreatment. And so the approaches that you take with different kinds of vaccines have been very different. So the groups that I'm working with right now are trying to roll out some vaccine related information, especially around myths and truths, just to give people the information that they might need in order to make an informed decision. And I think Dr. Fulalove gave a really great introduction to everything that I wanted to say, but I have a really short slide set that I'd love to be able to share with you, because I have a feeling the people in this particular meeting will be phenomenal ambassadors. So I want to give you a sense of some of the main things that we hear pushback from in the communities where we are doing outreach, so that you all can be well prepared to answer these kinds of questions. So the first thing is that the major reason that most people have any kind of hesitancy about these coronavirus vaccines is that they are concerned about side effects and that it might not be safe. So how do we work around that, especially when you look at even just maps of New York City, where the positive cases are definitely overlapping with our most diverse areas of the city? And so how do you push back against people who for many years have systematically received less care or worse care, and go through that and convince them to take a vaccine that has been brought to market very, very quickly? So let me just show you a little bit about the way that clinical trials are run. Phase 1, typical, and this isn't a typical kind of a situation, is 20 to 100 volunteers, and they are just making sure that whatever it is that they're putting into somebody's body is safe. It's usually a fairly low dose. They're looking for side effects. Right after that, they get a lot more people and they start to look at, okay, now we know what we're looking for. What are the side effects? What are the doses that we should be looking at? How they call these dose escalation trials. And then phase 3 has thousands, and you only advance if you are able to show safety, and then at phase 2, some amount of efficacy, and that it is protective. In phase 3, you're looking at thousands and thousands of patients, or volunteers usually, to see, is this an effective vaccine? That's the only question that they are looking at the end, because they've already got some amount of data on the side effects. And then in phase 4 is the approval process. You go through this EUA, this emergency use authorization, only when we are in a pandemic and when there are no other approved methods for treating whatever that disease is. So over here on the right is something that I stole from the BBC. And in blue, you can see it usually takes about 10 years to go through the preclinical analysis in mice, the small numbers of people in phase 1, then phase 2 when you're escalating, and then regulatory approval. And then only once something is approved do the pharmaceutical companies start to manufacture the vaccine in bulk. What happened now is that the preclinical phase was really short. Phase 1 and phase 2 were overlapping. Phase 3 was also overlapping. The regulatory approval went really quickly, and most of the pharmaceutical companies took a risk in starting to stock up their vaccine in large quantities before it was approved. Usually this is a complete no-no, and pharmaceutical companies that are often driven by profit will not even start to increase their amounts of vaccine until after approval, whereas Pfizer started last year, knowing that hopefully in a best case scenario, they would have approval in December, and that was the way that they were able to hit the ground running. Furthermore, we had the genome of the SARS coronavirus too in January. So they were able to start looking at this new platform of mRNA vaccines. Is something that actually has been researched for years and years and years. This is the first effective deployment of them, but the technology is not actually so new. And the financial support, largely from governments that committed to buying vast amounts of vaccine, gave the pharmaceutical companies a little bit more reward. Let's walk through these 3 different vaccines, the Pfizer BioNTech and then the Mrna. The Pfizer vaccine was tested in over 46,000 people in 39 states, and they tried really hard to make sure to distribute this within Hispanic, Black, Asian, white, and other groups. Almost 40% were in age 56 up, and there are trials ongoing right now in those age 12 to 17. The Mrna vaccine had over 30,000 people enrolled in 32 states. And again, you can see the ethnic and racial distribution there, and 64% were over age 45. Now, the Janssen J&J vaccine that should be filing for its emergency use authorization later on this week was tested in over 43,000 people, and largely in those who are over 60. Do they work? Yes, they work amazingly well. So both Pfizer and Mrna are 2 shots. Pfizer is 21 days apart. I got the Mrna one that was 28 days apart. What we mean by 95% efficacy or 94.5% efficacy is that they look at all of the people that had this. They saw that there were 170 who got coronavirus and that went on to becoming COVID-19, and they looked how many of them were in the placebo arm that just got saline injected and how many were in the vaccine arm. And through the math that comes through there, 170 minus 8 over 170, you end up with 5%. Subtract that from 100, you get 95% efficacy. So the J&J vaccine, all that is out right now is a press release. The full documents aren't out there. They declared that there were 468 infections, but we don't yet know exactly how those have come out. So what we are going for is herd immunity. And this is this nifty video that I've found. And what you want to look at in here, yellow are those who are vaccinated, black are those who are infected, and the purple are those who are uninfected. And when you see that there is nobody that's vaccinated, you see how quickly it spreads. You get a little bit more in the community, and it's, whoops, here we go, sorry, back again. And you start to see the effects of where we're at right now is at about 25%. So there could still be vast amount of community spread. Where you really need to be is above about 90% of your community has to be vaccinated in order to truly squash a pandemic. So let's go through, I want to arm you with the ways to answer these common myths with the truth that comes in here. The first one that we hear most frequently is these mRNA vaccines, they're going to enter your DNA and they're going to change it forever. Well, the best metaphor that I have heard is that you've got to think about this like a bank, all right? The mRNA is going to come into your cell, but it's only ever going to get into the lobby. It will never, ever break through into the vault where your DNA is. It's just not meant to do that. And the mRNA that gets into your cell is only going to last for about 24 hours, long enough to mount an immune response, but not long enough to stay and do anything lasting. Next, this is going to impact my fertility. It's just not possible. This is not the way. I mean, most of us have had vaccines for our whole lives and they haven't changed our fertility. Furthermore, there is no impact, and this has now been studied, on ovulation, on sperm generation. Furthermore, one other thing that a lot of people have wondered about is whether or not pregnant or nursing women should get the vaccine. That is something that there is ongoing research about this. It's something that people should talk to their providers about. However, in the 90,000 people who got the vaccine, many of the women became pregnant in between their shots or after their second shot. And now with over 60 million people who've gotten it, there's a lot more data on women who have become pregnant and men who have impregnated women post-vaccination. The MMR vaccine causes autism. And so therefore all vaccine cause autism. Well, the first article that ever published and claimed that was fraudulent and was retracted and has been disproven millions upon millions in millions upon millions of patients, hundreds of millions of patients since then. There is no causative or correlative relationship between the MMR or other vaccines and autism. Next, if I already had COVID-19, I don't need the vaccine. You can still benefit from the vaccine. It's unknown how long you will have neutralizing antibodies from having been infected with the coronavirus. So there is still an opportunity for you to gain some amount of protection from being vaccinated. They're going to microchip me when I get my vaccine, or there's these nanobodies in there that are going to last and they're going to be able to show me. So the smallest microchips that you can have are about the size of a grain of rice. And so I'm showing over here the size of the needle that is required for implanting a microchip, mostly in pets, right? But then you can see the size of a vaccine needle. Furthermore, if we can look at how fumbled the government has been at the vaccine rollout, I'm not sure that they would ever be able to get themselves together to truly be able to microchip and then follow people around. And then furthermore, your cell phone is already tracking most of your movements. So if the government really wanted to know where you were, they'd be able to use your cell phone for that purpose. Okay, another myth, and I promise there's not that many more of these. I'm cognizant of the time. The coronavirus vaccine gives you COVID-19. So this takes a bit longer to explain, but it's parts. What the mRNA vaccines do is essentially give your cells the recipe for how to create that spike protein that gives it the coronavirus its corona, such that then your body says, hey, you're foreign, I'm going to recognize you and figure out how to remove you from the body. The J&J Janssen vaccine is a much more traditional approach to vaccines, but it does the same thing in that it gives your bodies the instructions to how to produce that spike protein and train your body to realize that it is foreign. It is only giving you that small outside part of the virus. It is not the whole virus. It cannot give you COVID-19. The COVID-19 vaccine was created too quickly and is therefore unsafe. Well, I think I already went through the each of the vaccines was tested in 40,000 some people. And when I looked up the other day, over 60 million people in the US alone have already been vaccinated. And there is very, very strict reporting of side effects that happens through a system called VAERS. And now when you go in for your approval, you also have to study and list everything that happened to anyone that got vaccinated. You take a group of 40,000 people, something is going to happen to that somebody in that group of 40,000 people. And you have to make the case that the vaccine was not what caused it. So here's a part of the EUA documents from Moderna, where they were reporting a serious adverse event, an SAE, in someone who got the vaccine who had an arrhythmia because they were struck by lightning. So these are the kind of side effects that you could anticipate having is you're unlucky enough to get struck by lightning. This had nothing to do with the actual vaccine. These have been some of the safest vaccines that have ever rolled out. Okay, if I get the vaccine, I can stop wearing a mask. So the truth here is that every single vaccine that we ever have just protects us. If you had the measles or MMR vaccine when you were a kid and you are riding the subway, somebody who had measles, and you managed to touch your face and you got it, you would be infected with measles. And for a short amount of time before your antibody response charged up and got rid of that measles, you could still transmit measles to other people. The same thing is true with the SARS coronavirus. Even so, you will not develop symptoms, you will probably not be hospitalized, but you still need to wear a mask. Okay, this is the last slide, and I just added this after a task force meeting earlier today. If I get the vaccine and I'm undocumented or an immigrant, the government will deport me or I'll never be able to get a green card. So this was confirmed today that New York State will not, has not, and promises never to report any data to the federal government, to ICE, or to Homeland Security unless it's in aggregate. Here's the 40,000 people that were vaccinated in New York City today. 10% of them were Hispanic or Latinx, 5% were Black, 20% were Asian, et cetera. 40% were female, 60% were male. Only in aggregate would that kind of information ever be reported to the federal government. So anyone who is an immigrant or is undocumented and has some hesitancy because they think that the government will then stop them from being able to stay or getting a visa or having access to food stamps, there's no repercussions to getting the vaccine. So that is the end of what I had prepared to say. Thank you.
Thank you. I know that Stephen Brown has a question for you. Go ahead, Stephen.
Thank you, Rosa. And just a moment, I want to thank you for putting this together. It's wonderful. So I have a kind of a general question, and then I have more of a specific, closer on, more to topic. I was very intrigued by the part about high schools with a high school student, so I was certainly perked up my ears. And I was curious, just are there any issues or nuances, good, bad, at any level for a high school student getting a vaccination versus any other age? And then specifically when it comes to concerns, I'm curious if there's any study or thoughts on the apprehension of let's say a high school demographic versus their parents. And I'm curious if there is any difference, or when you bring equity and race into that, what that looks like as well. But those are the two sort of questions that I have.
Remind me if I don't remember all three parts of that. First, only the Pfizer vaccine is currently approved for those age 16 and up. The other two are for age 18 and up. So there's only one that would be available even to high school sophomores or juniors and up from there. The reason, so the trials are ongoing. I am imagining that for those 12 and over, we will have the data probably within the next 3 or 4 months, and then it would probably be approved by the end of summer. Okay, so that's point one. Point two, why am I focusing on high school students? So I'm on the Community Education Council for District 2. So I have a bigger focus on when it comes to school and education and outreach. And that's the biggest part of my connections are to principals and superintendents, to Gail Brewer, because I'm one of the borough president appointees. So the other part of that is that high school students, and this is because this is also where I lecture the most about the HPV vaccine, because this also hits in that demographic. High school students are still in a growth and an educational mindset. They're still somewhat deferent to authority, and they haven't yet been completely versed in Facebook and social media anti-vaccine campaigns. Fourth, they are the ones who can be the best ambassadors that we have found so far to their parents and grandparents. And fifth, they are the ones with the phones, the smarts, and the know-how to navigate 15 different websites to find the appointments for their loved ones that are older and are eligible. So it has less to do with the fact that I'm anti-adult and more that I want to try and hit a sweet spot that I think will actually be more effective from the beginning. The other part of that is that I'm one of the, and this, I don't mean to sound egotistical, I'm one of the content experts on here, and I have a much longer, bigger slideshow, and these are actually just very, very preliminary slides that I made myself, but I'm working with a designer. I am deploying train the trainer sessions to Black and Latinx graduate students, medical school students, and faculty to train them. And those are the people that I am putting in front of our high school students and their parents and those kinds of audiences over the course of the next 4 weeks. So even though I'm going to train them in what this content is and make sure that they have read everything so that they can answer as many questions as possible, I think there is, to kind of segue into the third part of your question, where does the racial empathy side of this come from? To a certain extent, these are all scientists and physicians. They're not sociologists. And that was actually one of my apprehensions about joining you all tonight, was that I'm also not particularly well trained in healthcare disparities. What I want to do is try and meet people where they need to be met with fact, and to say, here's a bunch of people of color who have gotten vaccinated, who believe in this, and are going to explain to you why they think that, and give you, the whole thing is coming from a stance of, let me give you the information that you need to make a decision on your own. And I hold you in no judgment if you decide not to get the vaccine.
Thanks.
I think I answered everything, but please remind me if
one nuance to the beginning. You clarified kind of who would get it, but anything, is there any nuances of who, whether you're high school, 16, 17, 18, for them to get the vaccinations versus adults, or is it, pretty standard across the board? Doesn't matter if you're 90 or if you're 15, it's sort of the same things, concerns, everything is taken into consideration.
Correct. Yes, absolutely. What you just said. I mean, if you remember that video on herd immunity that I put through, it's not going to matter who it is. The fact that the 90-year-olds are more vulnerable, that if they get infected, the sequelae can be much, much worse than in a healthier teenager, like a late teenager or football player or something on their school's team. They're probably not going to have as difficult of a course if they did get infected. So it's... but it's going to take all of us, and it's going to take everyone, but there do need to be priority groups. And that's something that the city, and we're not alone in not getting it right, but there are many of us, there are many places that haven't quite gotten the prioritization scheme right yet.
Thank you. And just, if I don't know if you can share the deck afterwards, I'd love to have the deck. I'd love to have the deck if that's something that's possible.
I'm happy to send this to you, but I promise I'm putting together something that's actually much, much, much more sophisticated, that's about 40 minutes long for our students. And hey, if you guys want to have us back, have my colleagues come back and give a longer thing. It starts with everything from, do any of you have any idea how many cells there are in the human body?
Trillions.
How many trillions?
30 trillion.
You're right. Now, do you have any idea how many microbial cells? Is it more or less than human cells in your body?
It would have to be more.
More.
39 trillion. So it starts from that, like that we should not be so afraid of bacteria and viruses. Do any of you have any idea how many viruses there are out there? 10 to the 31. Okay, so a 1 with 31 zeros after that. But how many actually infect humans? At this point, we only know of about 200. So it starts from like these kind of facts through like, how does the immune system work? How do vaccines work? And then some of these slides are in there as well. So I will be happy to share, because I really don't care if my name or the Sloan Kettering logo is on any of these slides. The whole point is for people to have the information that they need to make these kinds of decisions. And as Dr. Fullilove was saying, right now, we don't have enough vaccines for all the people who want them, but at some point we're going to get to a stopping point where only 50% of the population will be vaccinated, but we need to get well above 80% in order to truly get rid of this virus.
Well, thank you. And I didn't know math was on the test, but I'll.
What somebody told me was that high school students are not great, you know, especially in the later afternoon and evening, at staying engaged for another 45-minute long lesson unless you make it interactive. So I am taking that lesson and doing what I can to make things interactive.
Your colleague, Dr. Samson Fine.
Yes, I know Samson.
Is my son.
No way.
Yeah,
Oh,
he said you were terrific, and he understated.
Oh, I appreciate that.
Okay. Robert?
You're going to have to indulge me in trying to unfog this information. It's a lot. Now, do I understand correctly, like the HPV vaccine is an anti-cancer, is a preventive anti-cancer? Is that a particular cancer or generally? Is it a general vaccine for cancer period or what?
So if we look at how many people are in here, 50 participants that are in this call right now, 48 of us have been infected with HPV. Okay, it is one of the most common viruses that is out there. And there are about 51 different HPV strains. 4 of them are the most cancer causing. And then there's another 2 HPVs that cause genital warts, both genital warts as well as anal warts. There is a vaccine, the one that is currently approved against 9 of the most prevalent strains of HPV that 100% prevents all genital warts, as well as vulvar, vaginal, cervical cancers, as well as head and neck cancers. It is transmitted through touching, usually genital to genital contact, as well as deep kissing, as well as through oral sex. So while the most of the cancers that are caused by HPV are rectal and cervical, the largest growing number of cancers that are caused by HPV are head and neck cancers, so cancers of the oropharynx. And they are 100% preventable by the HPV vaccine, which currently is only approved from age 9 to age 45 through a lot of lobbying, at least at MSK. It's now approved through age death. So I did a lot of lobbying, and so anyone who's at MSK can get the vaccine. But the thing that they did, when the pharmaceutical companies rolled this out, sorry, I love the HPV vaccine. I could talk for an hour just about this as well. So please stop me or like grab a cane or just mute me. But
well, let me interrupt you. And your information is really terrific. But you addressed an issue that I recall from between 7 and 10 years ago, the early launching of the trial. I think that and the controversy was around dispensing the vaccine among adolescent girls, essentially, and the pushback from parents.
So it is now,
even if it was
boys and girls.
Has that been, has that controversy been assuaged in any way? Or?
No, and that's part of what the issue is with larger uptake of this vaccine. So we all, well, for those of us who have children and all of us got the HBV, the hepatitis B virus vaccine when we were 2 years old. That is also a sexually transmitted virus. And it did not cause increased promiscuity in any of us because, you know, or at least there's no study that I know of that showed that vaccinating someone at age 2 causes them to be more promiscuous later on. And it also, the HPV vaccine just protects you from HPV. It doesn't protect you from HIV, gonorrhea, chlamydia, any of the other things. So it doesn't give people license for increased promiscuity. And there have been an enormous number of studies that are showing, again, zero correlation whatsoever in HPV vaccination and increased sexual activity. So what was very foolish at the time they did the clinical trials was that Merck and GSK, GlaxoSmithKline, they said 7th graders have to get the meningococcal vaccine that's like a national mandate to go to 7th grade. So the whole point of giving the HPV vaccine is that you want it to happen before there is sexual contact. So they tested it in those age 9 to 11, and it's usually recommended at about age 11 in most pediatric practices. If they had done this, and the trials are ongoing, at age 2, we would not be in the same place where we are right now. There are certain countries that have vast uptake, and certain states in the country that also have vast uptake of the HPV vaccine, and they will be able to eliminate cervical cancer in a generation.
Is that why I recall that the controversy was really around girls? It wasn't about boys. So that, and I think that's where the parental pushback came from. Why are you concentrating on my daughters? And I don't know, I raised a son. So, but I was, that's a mixed blessing for whoever chuckled there.
I have 2 sons, and I convinced them by looking at them and saying, "Do you want warts on your penis?" They said, "No, give me the shots." And it was easy.
I want to interject here in the interest of time, if that's okay. I'm sorry, folks, but we still have, I believe, at least 3 presenters, and it's 8:30, so I want to make sure that we don't run out of time. With Rosa's permission, I just wanted to ask Dr. Neal one clarifying question about what she said earlier. And then I suggest we go through the presentations and hold comments until after. Is that okay for a plan? Is it okay with Rosa? Okay. So I just wanted to ask one clarifying question of Dr. Neal because of something that you mentioned earlier. Since having, and this follows up on what Helen Councilmember Rosenthal initially raised, since public data having
Oh boy.
Catherine, you froze. So maybe if you can put your question in the chat, I'll be happy to answer it while the next person is speaking. Does that seem fair?
Yeah.
Okay.
And again, I apologize for taking so much time. This
Oh,
is
no,
a topic about
no.
which I'm so super passionate.
We
so
wanted it.
appreciate the feedback.
Yeah, and we hopefully can schedule a follow-up with you so you can give us more.
Great. Thank you.
This is a big one. Yeah, this is a big one. Okay.
Catherine, are you back? Or did she just?
Okay, I'm back. If you can hear me.
Yes, go ahead.
I'm so sorry that I was on my phone and it died. So I'm back if you can hear me. So the question that I had is since public information is so important to have to be able to assess equity and access, and also for hospital partners to be able to contribute and help address problems, policymakers and community-based organizations and others. Can you clarify what hospitals are legally allowed to publish and what not? Because I know for institutional review boards data for that kind of research, you can't share confidential information about individuals, but hospitals can certainly share aggregated data or results from surveys. And that kind of information could be really helpful for the public and for hospital partners to have. And
So
so
Catherine, let me interrupt you there and just say that, you know, many hospitals will survey their patients, but there is also an independent organization that's called Press Ganey that does its own independent surveys and then publishes all of that. And then the group ProPublica also tracks outcomes of specific physicians, specialties, et cetera, and publishes all of that data. So much of it comes from CMS, the Centers for Medicare and Medicaid services. So any information that comes through that way, that is all 100% public, and people mine that data and put it out, as is Press Ganey. But when it comes to the stuff that and listen, I do not mean to speak for Mount Sinai and the way that they collect their data. And I'm also not in hospital administration anymore at MSK. So my thought is just like, when we are collecting satisfaction scores and feedback from our patients, it's usually towards what they were saying, like, how do we pivot and make things better? I just don't know enough to give you a better answer than that, other than to say that there are independent organizations that essentially name and shame hospitals that do poorly.
I just, thank you so much. I just wanted to clarify that the IRB data was confidential information, and that an aggregated data is easier to share with the public.
Absolutely, it is. I mean,
Thank you.
oftentimes you still need to get IRB approval. For those of you who don't understand the acronym, it's Institutional Review Board. So anytime you're going to do something with a human, you have to get permission. You have to tell them what you're going to do in advance, how many people, what are you going to do? It's also true, they call it IACUC, the Institutional Animal Usage and Care Committee, for if you're going to do it with animals, and you set pain thresholds, what are you going to do, et cetera, et cetera. So yes, IRBs are very specific, both about statistical power as well as what you can reveal publicly.
Great, thank you so much. And we're gonna quickly move on to Lila Mejia, because she has to leave right after. So Lila was born and raised on the Lower East Side. She has dedicated her life to advocacy. Her work is grounded in her desire to empower her peers. She's an organizer advocating on behalf of low-income families and a champion of preserving affordable housing and education as the vice president to the Community Education Council. She's a mother of 6. She currently runs one of the Henry Street Settlement food pantry programs due to COVID-19. And I'm just going to go ahead and let her speak because I know she has to get going soon. Thanks, Lila.
Thank you guys for having me. Can you hear me? Everyone hear me? Good. Thank you everyone for speaking. So like I said, my name is Lila. I run one of the food pantry programs in the Lower East Side at Henry Street Settlement. Just a little backdrop. I am an organizer, advocate. I have been on the ground since COVID hit. I was originally working for the Public Advocate's Office, and I didn't feel that they were doing enough. So I quit my job and started volunteering in the NYCHA developments. One thing about the Lower East Side is that we are on the water, and our waterfront is heavily populated with NYCHA developments. One of the main things that happened after COVID is I saw a huge food insecurity that was going on in my community as a single mother raising 6 children. I realized that a lot of families were struggling, right? And it wasn't just parents, it was also our vulnerable population as well, getting access to food. And so I teamed up with the TA president for Baruch Houses, which is the biggest NYCHA development in Manhattan with over 5,000 residents. And we called on our elected officials to help us. We are blessed that our elected officials, Carlina Rivera, Harvey Epstein, Yulene, and Nydia Velasquez are hands down amazing. They came to action. They continuously help us. And so doing a lot of this day-to-day work, we realized that, you know, and I know a lot of people hear, oh, well, Gail Brewer did food and Fresh Direct and City Harvest. But what a lot of people don't realize is that in Black and Brown communities, we were getting the short end of food, while other communities, the affluent communities, were getting the vegetables and the fresh stuff, and we were getting not the fresh. So it was always, since day one, us organizing and fighting so that we can have equity of food food distribution, right? And we're still fighting for that. And I think what a lot of people seem to forget is that our kids are home and our kids are hungry every 3 minutes, right? And so if you're used to bringing your kids to school, now your kids are home and all they do is eat. They didn't eat this much in school because school lunch sucked. Everything in school was disgusting. So our families are spending more money. We're seeing more families struggling, as everyone knows. It's hitting all our communities. But which partners with this is that because I advocate and I organize in NYCHA developments, NYCHA specifically was left out of the conversation when it came to COVID, right? Our families were not educated, our buildings were not cleaned. There was a huge gap of communication between NYCHA and everybody else. But then now we're being thrown this vaccine to our families saying, here you go, you got to take it. And one thing that I have encountered, because I literally every day door knock, and once I'm done with this, I have to go give food out to some families because they're COVID positive and they can't leave their house, right? One thing that I have come across is that people of color do not trust the vaccination. I am one of those people of color, someone who read medical apartheid, who knows the history of our country and how our country is tainted in racist policies and practices. We, not all, but a lot of Black and brown are choosing not to take this vaccination. So we've had vaccination pop-ups and they're just not being, the people are not lining up. Right? We do have families who have taken it, and I encourage anyone, if they feel that that is correct for them, go for it. I'm never going to put my judgment on families, but as we connect with our elected officials and we're trying to have more access for our families as far as food and vaccinations, we encounter families who say that they are not comfortable with getting vaccination, or it's too soon, or where was the discussion, right? NYCHA did not provide any kind of COVID testing. We had to fight for that. But now NYCHA wants to make sure that our family, Black and brown people, are getting vaccination. Those are huge pockets in our communities that a lot of us don't feel safe, right? And so a lot of the work that we do is making sure that our families are educated, making sure that our families are knowing these things, and also providing the food, right? Because it all ties together. Housing, food justice, health justice, that is all one big kind of like Earth ecosystem of stuff. And so that's a lot of the work that we do at Henry Street Settlement. It's a lot of work that I do. I'm blessed that I sit on the CEC 1. I know there's another CEC 2 person. And so it's also the education component as well. We have been blessed that we have gone to our Title I schools, and I think my CC1 president is on this call. Shout out to you, Naomi. We've distributed food boxes to our Title I families, right? Because our schools know our families best. They know the families who are struggling. They know the families who need the assistance. And I will add that we don't do pop-up food distribution. We do in-home delivery service, right? Because those are the families who need it the most, not the folks who could come outside, right? And when we do our work, I like to think about my 6 kids. You know, am I able to go outside all the time? Absolutely not. I'm fighting with a 3rd grader, a 5th grader, a 7th grader. My twins are in 12th grade and my oldest is in college. You know, do I have access to go outside and get a food box? Can I go out and do that? Do I have money? So it's just making sure that our families are safe, that our families are getting food access, and that we're having these conversations with Black and brown folks, because I'm in a lot of spaces where people say, oh, they're just ignorant. They just don't know. It's not ignorance. It's absolutely not ignorance. Looking from the history of our country, Black and brown people have been tested. You cannot be mad at folks that they don't want to get tested. But how do we change that, right? How do we bring these resources? And when we bring these resources, bring it to people where they look like us, right? They look like the people who service that community. Because I would trust a tenant leader before I trust someone, one of you guys coming into my neighborhood saying this is what you deserve. Absolutely not. It's not going to work that way. So I don't want to say much because I also want to hear any questions, and I apologize because I have a Zoom at 9 as well. I'm like running around, but I'm super blessed. You know, Rosa, you hit me up. Thank you guys. If you have any questions, ask. And I'm always looking for volunteers. We always need volunteers to help distribute food.
Go ahead, Richard. Go ahead.
Richard?
Yeah, hearing you right after Dr. Neal, I like a kind of a conversation between you. What is it that she can do as an advocate for vaccination that is specific to the non-white community. I know there's a huge amount of history of the Tuskegee incident and others. And on the other hand, this vaccine has been taken by the president, the vice president, every other white dignitary. Is there something that she could add to her slide deck or her presentation that would be specific for your community?
I mean, we can always have that sidebar conversation because it's not just my community, right? It's your community. It's a lot of communities of Black and Brown, in which also when we do presentations, we have to make sure that we are making sure that our community understands it, right?
Yep.
And we're using language that our community understands. And we're speaking the language that our community speaks. And I think that's also a huge factor that I didn't mention, right? In my community alone, it is heavy with Spanish-speaking, Cantonese, and Mandarin. And there's a huge disconnect with services from the vaccinations to food access and to any other kind of situations going on in the neighborhood.
And I would just say that I 100% agree with Lila. And that's why I'm never going to be as effective of an ambassador as many of my colleagues will be. And so I want to arm them and prepare them as best I can to be the ones delivering that message, because it's going to ring true so much better than it would from me. And I also agree with what Lila was saying, like, we're not going to convince everyone, and that's also fine. These are extremely personal decisions. I can see it in black and white, but other people can't. And I don't have your lived experience. And so I can't pass judgment. And I just want to be in a place where I find as many ambassadors as I can, get them well trained with the information that they need. And a lot of what I have heard, and especially from my colleagues that we're training, is that when they talk to their parents or their colleague, their friends, their neighbors, that they're saying, I just don't trust it. And how do you combat that? Well, I mean, I'm trying to combat it with facts, but I also realize that Lila's approach is probably going to be more effective in terms of boots on the ground than holding Zooms, but at the same time, that's also part of my strategy of going after high school age students, is priming the ambassadors to be the ones to deliver the information. It's going to take all of these different kinds of strategies to get there together.
Thank you, everybody. We're going to move on because we're running out of time. So I want to present Council Member Helen Rosenthal, who represents the Upper West Side and the city. She's a leading voice on issues of gender equity, adequate funding for social service providers, civic engagement, accessibility, affordable housing, and education equity. Council Member Rosenthal.
Thank you, Lila.
Lila, sorry. Thank you.
Dr. Neal. Wow, that was amazing. I just really enjoyed hearing you both. And want to thank you all for coming on. Rosa, this is a phenomenal panel, like a bevy of riches. Can I just let both of you know the highlights of what I'm going to speak about before you jump? You're jumping in like 14 minutes. Basically, so I'm the council member that has represented this district for the last 7 years. During this second term, I've been chair of the Committee on Women and Gender Equity, and we've been looking specifically at many of these issues. Obviously, with the pandemic, it shined an enormous spotlight on the entrenched racial and economic health disparities across the city. I was trying to look on the Department of Health website. They do have quite a bit of data on there. If you look at the COVID maps, you can see the geographic areas most populated by Brown and Black individuals have the highest rates of mortality from COVID. And the truth is, Lila, you rest on the shoulders of other terrific community advocates and local healthcare providers, researchers, and some in government who have been raising these disparities for years. So there were two particular areas of public health disparity, which I've tried to tackle as a legislator. The first one, front and center, is maternal mortality and morbidity. It's one of the biggest public health crises in the country. But despite alarms sounded by Black and Brown communities and many community-based organizations in New York, the city has not been as aggressive as possible in its response. I mean, there are great people, there are dedicated people in our hospitals and the health department who are working to improve outcomes of mothers and babies, but as a whole, as a city, we are failing, and it is directly linked to racism in all its forms: structural, environmental, direct and implicit. And Lila, I think it was you who mentioned that you've read the book Medical Apartheid by Harriet Washington. Oh my God. Like, you read this book, between that and perhaps they'll read it in their book group over at Mount Sinai, because she tracks how history of slavery gets us to where we are now, where Black women are 8 times more likely to die from childbirth compared to white women. You know, in 2010, that number was 12%. So I give the Department of Health some credit in improving to 8%, but that means that at 8 times more likely, it means that Black women, and this is really just about the African-American community, Black women are 800% more likely to die than their white counterparts in childbirth. And this is just death. It's multiply each of those by 1,000 cases, and you get the morbidity, you know, the near-death experiences during childbirth and afterwards. Serena Williams, I mean, who even tried to advocate for herself, was told she had a headache. But had it not been addressed, it was really a blood clot. And we know that the Black infants in the city are also 3 times more likely to die than white newborns. So in the council, we've had hearings, and my committee on women and gender equity, we had an oversight hearing examining the mortality crisis. And we heard 2 of my bills, which happily have since become law. They were both embraced by the Department of Health. And for those of you following city council hearings, more often than not, the city administration, you know, is fully opposed to being told what to do. They don't like these bills that are so prescriptive, but Department of Health welcomed them and actually made them a little bit better. Local Law 187 requires the Department of Health to assess the needs of pregnant people and the availability of doulas to meet those needs, and to increase access to doulas for communities experiencing disproportionately high rates of maternal mortality. And we can talk about doulas later if anyone has any questions about that. The law also requires DOHMH to provide an annual report with information about available doula services, plus data on neighborhoods experiencing high rates of maternal mortality, infant mortality, and other poor birth outcomes. The second law, 188, also seeks more accountability from the city. We've required Department of Health to expand its reporting on maternal mortality and morbidity. And we've made the department's M3RC, the Maternal Mortality and Morbidity Review Committee, permanent. And this gets back to sort of my questions to some of the Mount Sinai folks about the data and making it public, because in that way, advocates and those paying attention can raise a red flag as they're seeing, all these disparities. So transparency, I think, is critical. And unfortunately, there are huge delays in getting the data on maternal mortality from the Department of Health. So we still won't know the information about 2020 for some time. And so it drives home this very sobering point. We know very little about the experience people are having giving birth during COVID-19. And the data is gonna, root this out. But what we do know comes from the press. And we know that several women have died in childbirth since COVID, including Amber Isaac, a 26-year-old Black woman who left a chilling final message about her experience with healthcare while she was pregnant and waiting to give birth. We know that for a period of time, people giving birth in hospitals were without birthing partners, had no one to advocate for them, to witness any mistreatment, or just give them support. Secondly, and this has to do with much broader systemic look at healthcare. Just a few days ago, the council passed 2 pieces of legislation I sponsored, which seek to advance better conditions in our healthcare institutions and therefore better outcomes for patients. I've learned from healthcare professionals who've worked with me on these bills, better outcomes depend on rooting out the systemic racism and misogyny in the healthcare system, from academic institutions, medical schools, to private and public hospitals and other healthcare institutions. So one of the bills establishes a multidisciplinary advisory board convened by the city's Department of Health, which will study workplace, gender and racial discrimination of all types, how it impacts conditions for healthcare staff, including residents, interns, faculty, and housekeeping. Obviously, these impacts eventually manifest in patient care. And here too, the data speaks for itself. Over 2/3 of women physicians have reported sexual harassment, according to national studies. A 2018 report by the National Academy of Sciences, Engineering, and Medicine found that up to half of women medical students report some form of sexual harassment. And the number is even higher for students of color. So the advisory board will issue annual reports detailing workplace discrimination and recommendations to address it. The report, and again, this gets to the transparency, it'll be sent to the mayor and the city council, but also, as required by law, hospital trade associations like the Greater New York Hospital Association. And that's why I was asking the questions to Pam about, and, are you talking to the board president, the board presidents, let alone the hospital presidents? The truth of the matter is, more often not, these are people who were educated in medical school, in what, the 60s, the 70s, and, were learned mnemonics with these racist and sexist, phraseology that's incredibly offensive today, but that is how and when they were trained and then brought up in the hospital system. So the first report is due December 1st, 2021, and we'll see what happens. I have to say, my legislation was inspired by current and former Mount Sinai employees who filed a federal lawsuit in April 2019 against Mount Sinai and 4 of its male employees for sex, age, and race discrimination. And as I've said, I think this starts in medical school. So the council also passed my resolution calling on New York State to require medical schools to train all students about implicit bias, which is defined as attitudes or stereotypes about people which are held without conscious knowledge. Training in implicit bias is a critical step toward understanding and fighting explicit bias and systemic discrimination, both of which can and have contributed to the worst health outcomes experienced by New Yorkers from traditionally marginalized communities. There are 2 state elected officials, State Senator James Sanders and Assemblywoman Karina Reyes, who are carrying legislation at the state level to require medical schools to train about implicit bias, which is incredibly wonderful. I think that passing this legislation is one step of many that are needed to address the historic and ongoing discrimination that plagues our healthcare system. And I want to conclude with the words of Dr. Carrie-Anne Chalvoy, the president of the Committee on Interns and Residents, SEIU, quote, "The only way to work toward real equity is by creating systemic change at every level of the healthcare system, and to hold institutions and individuals that perpetuate injustices accountable," unquote. So thanks for sticking around and hearing that. I'd be happy to answer any questions now or later.
Thank you so much, Councilmember Rosenthal. We want to give Padmore John some space to talk as well, because he's our last presenter and we saved the best for last. Padmore John, thank you. Councilmember Rosenthal, we'll get back to questions. Padmore John is the manager of the East Harlem Health Action Center, which is under the Bureau of Health Equity in the New York City Department of Health and Mental Hygiene. Thank you so much for waiting. We're so happy to have you here.
It's a pleasure. Thank you. I appreciated everyone that went ahead before me, and I learned a lot from them. So it definitely was worth the wait. I'm not going to take up too much time. I realize, and I know sometimes in these situations, it's always better to allow for questions. So I will do that. I will just start very briefly in just giving, if I can just share my screen very quickly, just in terms of showing some information on the latest data and where it can be accessed. It should be here. So I just want, this is, and I can put this link in the chat just to make sure that everyone has access to this. The New York City Department of Health has put up this website, the website for all the information around COVID-19, but most recently it has also started to include the number of doses that has been administered, the number of doses that has been delivered to the city. And you can all track that here relatively easily. And as you can see, the total number of doses delivered up to this point is 2,010,010. And the total doses that has been administered is 1,547,983. Of course, there was a challenge over the past few weeks, well, the past week, 10 days, because of the major snowstorm that disrupted distribution. But now we're starting to get a significant more of the doses back into the city, and those are now being administered through many of the sites across the boroughs. And I just want to also make everyone realize that there's a whole bunch of different organizations that have stood up sites. There's the city-run sites. Many of these sites we call in pods, point of dispensing, that are run by the City Department of Health. There's sites that are also being administered by the Health and Hospital Corporation. Then there are sites that are being done by New York State. Then there's sites that are being done by the federal government. Just 2 of them were recently put up one in York College in Queens and Medgar Evers in Brooklyn. And they are now accepting individuals' appointments from across different different zip codes within those very specific boroughs. So, and then of course we have the private sites, whether they're pharmacies or something like the Armory that was stood up by New York Presbyterian. And of course we have FQHCs as well that are being able to administer some of these vaccines. So as everyone has spoke about from first Dr. Fullilove to other panelists, it has been a challenge in terms of getting vaccination for certain individuals. But if you come down to the site on the same link, but just here in New York City, adults by zip, you'll able to see some of the zip codes and where they are. I believe this is around CB7 area. So we have 8% and adults that are fully vaccinated at 13%. Just to the west of that, 10024, we have 8% partially vaccinated and 15% adults fully vaccinated. If you go just slightly north, we see that percentage falls off, right? And that's where we start Harlem, Central Harlem, 5% fully vaccinated. Here we have 5% in 10031, 4% in 10039, 9% in 10032. And there are certain neighborhoods, of course, that when we work around on the Upper East Side, in comparison, 17% Upper East Side, and up in East Harlem, 7%. So there's a big 10% difference between, and we know the demographics of those neighborhoods and what impact that has. So obviously, just to let everyone know that, part of the purpose of capturing this data is, of course, as was initially mentioned, that once we have the data, we're able to know where we need an intervention. And there are a variety of things that the Department of Health is doing in terms of ensuring that there is access. One of the things that was initially spoken about by Dr. Fullilove is the partnerships that we are having with community-based organizations. As has been discussed numerous times here, being able to have someone that looks like you speak to you about the benefit of being of utilizing and the benefit of administering the vaccine speaks a lot. And so it has been, whether it's individuals of color within the Department of Health or partnerships with community-based organizations that has been working in these communities for quite some time, way before COVID, has been providing support, providing access to resources, and of course, building trust, which is something that can never be done overnight. And this is what many of these organizations are being able to utilize in terms of, one, allowing the individuals that they serve to at least just have an open mind towards the information that they're bringing. And I think it's very important that just made that point. It's really to try and provide as much information as possible so the individuals can make an informed consent. Councilmember Rosenthal, we've been doing some work on, and someone mentioned radical apartheid in terms of addressing the removal of the J. Marion Sims statue. And that is just indicative of a case where those individuals were operated on without consent, right? And I think right now what we would love to be able to do, what we're encouraging everyone to be able to have at least access to the facts so that they can make an informed decision. And it's very important, just in the case of what that decision is all about. It really is whether you want to take the vaccine or whether you're not, to make a plan, right? If you're going to take the vaccine, there is a plan, and I can speak to that a little bit in terms of the scheduling, in terms of being able to work with a community-based organization so you can get your appointment. So you know that you're going to be waiting there an extra 15 minutes after you have received your vaccination because you need to be observed. You may need to get transportation back and forth, especially for seniors. So how that's going to be happening. So there's a plan towards getting the vaccination and getting back home. You know that within the next 3 weeks or 4 weeks, according to the one you're getting, you're going to be getting another dosage. So you're not going to be going out of town. That's the type of stuff that you're doing. And it's a plan to make sure that you're being appropriately protected. And similarly, if you're deciding to not get that vaccine, as we have heard earlier today, what is the plan for your protection? what are you making sure? And when you may say your neighbor is not getting it, so I'm not going to get it because they're saying a lot of things that are horrible. But does your neighbor and your situation are the same? Is your neighbor have multi-generational family? Is your neighbor going out on a numerous times? And is your neighbor working in a place where they're being exposed nearly every day? So these are some of the things that you really have to consider, and being able to make a plan to ensure that if you're not going to get that vaccine, as we all know that herd immunity is beneficial for the entire, for all of our community, that there are ways that you are not propagating, you are not transmitting, you are not being a carrier to cause any further propagation of the disease. So that's really important, and for us to be able to think. And I just want to speak to, we all know that there's a lot of vaccine hesitancy, and it has been raised numerous times in terms of a lot of the causes. But one of the things that we haven't really spoken about is just the lack of doctors of color, doctors of African descent, of Latinx descent. And that stems back, and I want to speak to just a little bit of the history and its impact today. In the early 1900s, the commissioning of the Flexner Report, I don't know how many of you may know of that, but the Flexner Report basically looked to standardize medical education across the country. And it recognized that Johns Hopkins University as the gold standard of what medical education needs to be. And any school that was not on that standard was suggested to be closed or to be able to raise that standard. At the time, there were approximately 10 schools predominantly serving African-American communities to get them into to become doctors. At the end of that report, there were only 2 left. And we still have that legacy, right? So today, there's a lot less Black doctors. Councilmember Rosenthal, you mentioned about the discrepancies between early young children dying and mothers that are dying. One of the key components of that, from what some studies have demonstrated, is whether or not the child or the mother has a Black or white doctor, right? So just as simple as that. And so 50% difference actually in the chances between birth and death between a Black and a white child just by their doctor. And so just in terms of the education that is coming to the communities that is now less because of the fact this legacy of the removal of many of these medical schools today. There's a lot less Black medical doctors. There's a lot less interest. And if we want to just take it to the point of, to some extent, what happened in baseball, one of the most, we perceive the most integral things that happened in baseball was the integration of baseball, right? Where Black players will now be able to play the Major League Baseball. But what we don't see on the other side is that Black businesses that were all around baseball, Black baseball players, Black stadiums, Black culinary individuals, entrepreneurs that were around baseball, they all lost their jobs. They all lost their standard of living. They all were depleted because there was no more Black baseball anymore. And so when we're thinking of, and this was how many years ago, and we're seeing that today, one of the least populated sports by people of African descent is baseball. So it just goes to say the legacies of these decisions, these policies that continue over decades and even centuries now, and how right now, as we're looking to have an impact to protect individuals from COVID, we need to be thinking right for this immediate time, but also 10, 20, 30 years in ahead as well. And for us to be able to implement policies that speak to some of the removal of some of these systematic oppressive measures, some of the policies that we know that we may think may be beneficial, but when we look at it deeply, it's not as helpful as we know that we can do. So just going back really quickly to COVID, and in terms of making sure that we're increasing access, for example, in the Upper Manhattan area, There are 3 or 4 different, not even lower down as well in terms of the location of one of the vaccine sites in the Ford Foundation, which is on 42nd and 1st and 2nd. We also have been managing a pod site, a point of dispensing site on 114th between 7th and 8th. That just had to be closed because the medical middle school is opening at this time, and it was a middle school, so it had to be moved to 135th and Convent, that's E. Philip Randolph. So obviously there is an opportunity for individuals to just go online and go through the process of getting it. But what we have been doing is working very closely with community-based organizations. These organizations are reaching out to other institutions within communities, whether it's churches, whether it's other sites that are providing resources to individuals, and then speaking to these organizations, identifying them, anyone who may be interested in getting the vaccine, and then assigning them slots so that they're bypassing the whole process of having to go through the online appointment, which has been very challenging, especially for people of communities of color. So that has obviously is not that many slots, and there were some challenges because of the recent storm. So we're trying to take that back up now, and it's being done across the 5 boroughs. I am being based in Manhattan, have been helping in identifying some of the community-based organizations and working with some of these organizations so that there's some of their clients and eligible staff are able to have access to this. We have also been looking specifically for seniors, some of the seniors that are having difficulty in transportation. There is a way, the city has now contracted with 2 agencies, CURB, and I can give those numbers in the chat, CURB and Hunter Ambulance Service, which will take anyone that does not have Medicaid. If they have Medicaid, they can utilize Accessoride. If they don't have Medicaid, whether they have insurance or not, they'll be able to get free transportation to any city-run vaccine site and back home. So that's something that we are trying to get the word out, and any challenges around that, we want to be able to make sure that we are elevating to address the concerns of any of the individuals that are participating in that. I'll leave it at there if there are any other questions, but thank you for being able to be here. It's always a pleasure. I serve on the board of Community Board 9, and we have been working very closely with Community Board 7 on many endeavors, and so it's always happy to be here again. Thank you.
Thank you so much. Now we have time for questions. Are there any board members or, well, committee members or board members who have any questions before we go out to the public? Does anyone have any questions for either of our last speakers? Oh, Shelley, go ahead, Shelley.
Okay, just, you spoke about having doctors from communities of color and how it's advantageous. I think the problem starts at a much earlier stage because I'm from the public education system. Who is guiding the young people in that direction? Who's encouraging them? Who's providing the background in STEM and other areas to lead them? But most important, who's guiding them? Coming from a background where no one went to college, going to college was a big thing. But to think about doing certain things, for me, there was no role models that from my family and from my immediate community. So much more in communities of color, okay? And so I think we have to do something about how kids are guided, even going down to younger grades. Just your thoughts about it.
Yeah, agree 100%. I think it's very important to have those role models to let everyone know I can become that. This is something I can do, and I encourage them to do that. And even to the point of going back and speaking to some of these to some of the schools, being able to speak directly to students, answer their questions, to give encouragement. And so that's something I 100% agree with. Of course, you know, it's always a challenge because there's so many, there's a dearth of medical providers or even scientists that are from the African American community. So being able to encourage them surely helps. I think NYU is one of the few medical schools that are now have cut their costs. There's no real cost to go to NYU. I think it's all practically free. And so this type of endeavors, I know Georgetown, for some of its science programs as well, they were also ensuring that some of the descendants of those that were enslaved at some point, that they were able to get access. So those, I mean, my alma mater is Johns Hopkins, and it was just recently identified that, and when I was there during the early 90s, not trying to date myself, we were all made aware that Johns Hopkins was an emancipator. And recently data came out that that was not the case, that, you know, he did not actually liberate his slaves upon his death, and that there was some continuation of slavery that went on the plantation. So how can Hopkins, in that case, give back to the community, encourage more? This is something that we were doing, but it was not very well funded. You know, when I was an undergraduate there, in terms of ensuring that students are seeing that this is something, you know, right here in New York City, a great and big university as Columbia that is somewhat gated, right? Even with no gates, there's still somewhat of a distinction between, is this a place that I can go to? Is this a place where I can walk through? There is an aspect of that. And so being able to have some of these institutions step up and encourage and provide that leadership in terms of encourage and the next generation that is coming up to be able to see this as a viable a career, and to encourage them as early as possible. So it's definitely something I think we need to hold them accountable for.
Yeah, I think you mentioned also the financial accessibility is huge.
Yeah, that is one of the very big barriers, because a lot of individuals are coming. I know I have a lot of friends who are physicians, and one of the things they're crying about is their the loan that they're paying back, right? Yes, they're making nice figures, but nearly, you know, a third of 40% of it is going to address those loans.
Mm-hmm. Thank you.
Good, Robert.
Yeah, I think it's important to, unfortunately, all of my frames of reference go back decades, but they're fundamental to everything that we're talking about. So that, and I use the Boriken, you say you're East Harlem, so the Boriken is the center that I'm talking about. One of the leading FQHCs. One of the issues that we had, we're talking 1973, it was open. We opened in 1973, that's when we have our HQFC designation and so on. It was the question of recruitment, okay? And the majority of the population seeking service at Boriken at the time was the Latino, mostly Puerto Rican population, a good part of that Spanish speaking. So try as we may, try as we did to recruit Latino and other people of color, physicians, internal medicine. In many cases, because they were bilingual, they were premium, sought elsewhere at institutions that could pay them big salaries. Now, of course, the physician that came through the Bureau of Primary Health Care as part of their community service and reducing their loans, their student loans, by providing service in their local community in an FQHC, were comparatively small number. And we struggled with that with medical directors, and we had the very finest. The first one came from Sinai, Dr. David Rose. He was it was considered, he was the love child, okay? He was a miraculous doctor, wonderful. But also as a manager, because you're dealing with a lot of young doctors and so on. And that the issue of recruitment, even if we wanted Latino, Black American, became a side issue. So, you know, we can't, we need fine doctors. I don't care what race they are. so that some of the finest doctors that we had were non-Latino. And their language was not a barrier. Somehow in the examining room, language barrier disappears somehow. And don't forget, a lot of the staff, the nursing assistants and so on, they're Latinos and they speak Spanish. You call them in to translate and this and that. But it's really a question of a fine doctor. So I don't know if a Black doctor, a white doctor, if you go to an area of the country that is resistant on the COVID note to the vaccine, a Black community, Alabama, Mississippi, wherever, the doctor primarily is going to be Black. He's going to be a very fine doctor. You know, it's going to maybe a folkloric figure. He's such a good doctor, known to that community. So it isn't the question of Black and white. It really isn't. Not in the direct patient care. The other nuances, the ancillary nuances of blind spots. Okay, and I run into them myself, and I have the very finest doctors up here at St. Luke's. My urologist and my vein man and my so on and so forth. They run the spectrum, but they have their blind spots. And I think it was the young lady, Layla, who said, you know, we understand that because you're human beings and I have them. And it occurred to me a couple of years ago that I'm the worst racist that I know, okay? I'm full of biases. And, but I have to challenge that notion that it's a question of getting more Black. We want more Black doctors, and there are plenty of them, but they're premium. They go elsewhere. They go where the big dollars are. They don't come to the FQHCs, you see? So that, but we still wind up with very fine young doctors that come in to serve in exchange for a discount on their medical education loans. And I forget the name of that series that was on TV for the longest time in the Northwest, and it dealt exactly with that. And it had one of the scenes that kind of underscores the whole exchange. And the head of the town takes this young doctor out on
Robert, I have to interject here because it's 9:30, and
I'll just finish this because this is the point.
Thank you so much for your comments. If I just want to make sure that other people who haven't spoken have the chance to ask questions. I know there's a lot of folks here that have questions for the speakers, and we also have 3 members of the public that have been waiting a long time, and I just want us to be mindful of the time. If you want to finish up the thought, I didn't mean to cut you off mid-sentence, and then let's make sure that we're able to hear from everyone, and especially I want to make sure we get to Rosa has a question, and the public.
Well, then I'll just do it very, very quickly if I can make the point. And it's the idea of the retention of doctors. And in this particular case, and this is a vignette that was true to the actual practice of doctors coming to the local center in exchange for their student loans. And in this particular case, the town leader, a guy who had a hunter, whatever he was, but he took the doctor who was the doctor for the town, one doctor for the whole town. And he took them out on a boat ride because the young man had misgivings. He said, you know, I don't have to put up with this just for a student loan. I can go to the other hospital and make some serious money. So he's taken out on the boat ride, and the guy just happens to have his shotgun with him, okay? And says, you know, you can reconsider all you want if you're going to help us and be here with us, and you're going to get all this discounted, this loan discounted, but, you know, there are consequences. You made a commitment. So the issue of recruitment, of who comes, who's willing to come to the local poverty community, the community of people of color, is an issue. And but at the end of the day, your standard has to be the best practitioner you can get, not Black, not white, not Chinese, whoever is a good scientist and can provide the care that you need in your community. And thank you for giving me that other minute, Catherine.
Thank you so much, Robert. Hand it over to back to Rosa.
Thank you. I just wanted to say thank you to Padmore John for that idea about a plan. It's something I haven't really heard too many people talk about, but that's so significant, right? I mean, it's all about, so am I gonna take the vaccine or am I not? And what is my plan from there? Because I don't think we think in that term. So to me, that was something so significant that I learned tonight, even though it's It's very basic. It's not something I don't think many of us are thinking about. What is our plan? What is our long-term plan? What is our short-term plan? And it's so important right now. So thank you so much for speaking to us and also for bringing that to light. And then I have a quick question for Councilmember Rosenthal. And I'm a union rep, and a lot of times the issues that I deal with are implicit bias issues in the workplace. And so I wonder, and it's difficult to hold people accountable to that. So how do patients who are of color, who are dealing with implicit bias issues, and generally they're things that are like under the radar, right? It's not anybody saying something explicit to you, but they're doing something to you. How do you hold those people accountable? I mean, let's say you are an immigrant and you don't know what your rights are, or you're afraid to speak up, or you think, oh, I just imagined this. A lot of the people that I represent are people of color who are administrative assistants at Columbia University and Teachers College and Barnard. And so a lot of times they are not in positions of power, right? They're serving white professors who do something that they perceive as a slight, and I think they're correct. A lot of times I'm defending them, but it's really difficult to defend them because they are really sort of under the radar things. They're not things that you can point to, but the person certainly feels this happened to me. I know this is because I'm a person of color. I don't know how to explain it. And as a union rep, I find it really hard to defend them a lot of times because now we're dealing with systemic racism, people in power who don't understand what we're talking about. So I wonder how you deal with that. Sorry, I went on and on. How do you deal with that in a hospital setting? Because that's even, I mean, at least with your employer, you're dealing with them on a daily basis, but hospitals or doctor's offices are a one-off. So what do you do? Like you're in this situation, somebody's treated you poorly, then what?
Yeah, no, it's spot on. I certainly don't have any good answers. I mean, especially in the doctor's office, how do you deal with that except for take your business elsewhere? But there are some doctors who are attendees. If they want to put answers in the chat, that would be very welcome. It is what this advisory board is hoping to deal with. We went out of our way in writing the legislation to try very hard not to get the hospital professional whose title is, you know, diversity vice president, and instead to get advocates, union representatives, people who can speak up about this, you know, because the vice president for diversity, you know, their employer is their white doctor boss. And, you know, it truly was appalling to me when the lawyer who came to, the lawyer for Greater New York Hospital Association, who came to testify about some of the legislation, really had no interest in trying to educate the physicians, the doctors who are now presidents of hospitals and members of Greater New York Hospital Association. You know, I'm not sure they would even read the book, which was Mount Sinai's solution was to have a book club. You know, as well, we should check the chat. So Rosa, if anyone's answered in the chat, we should surely look at that. The issue of safe reporting systems for patients and employees facing discrimination is key. The systems for reporting and adjudication need to be independent of hospitals and the clinics themselves. Spot on. And Anu, who is writing this, was instrumental in writing this legislation. I'm hoping she joins the advisory board, is appointed to the board. You know, the other resource for people is the city's Commission on Human Rights. And they're there to take on these kinds of cases. So that's another avenue. But, you know, we're talking about systemic racism, which by definition, the institutions that perpetrate this racism are resistant to change.
That's the same issue we face with professors, for example. It's just so embedded that it's difficult to remove that. I'll leave it
government as well. I'm sure, you know, if you look at the city council, you know, 25 of the city council members are white men. White men. That is not representative of the city's population at all.
I know we have some questions from the public, so I want to make sure we have some time for that.
Can you see the list, Rosa? Or the sign-up sheet, or would you like me to tell you?
Yeah, please tell me because I can't find it. Sorry.
Sure. The first is Mrna Vaccines.
Oh, Buccio.
Buccio, thank you so much. If she's here.
I don't see her on the list anymore.
Okay, the second person signed up is Thomas Caffrey.
I think he's gone as well.
Okay. Third person, and please forgive me for mispronouncing names, is Adelia de Almeida.
She's here.
She's rejoining as a panelist now. She should be able to speak.
Wonderful.
Adelia?
Yes, I'm here. Good evening. This is not the first time I'm here. I have a quick comment from Mr. Padmore. I'm a brown person, and the first opportunity I got that I qualified, I was on the computer for a whole day trying to get a spot to get a vaccine. And I think this country is brilliant to come out with this 95% protection. And I already took both vaccines. So not every brown person is afraid of the vaccine. Now I have Ms. Rosenthal.
I'm here. Just eat some dinner of popcorn.
I called your office several times. And there's a problem with the former Days Hotel. It's an illegal hotel with illegal homeless. Now crack dealers moved in. I have one right on my side here. Your office is telling me to call the police. So I went to throw my garbage and it smells like ammonia, the whole floor. There's people smoking heroin. There's a crack dealer right on my side. This is a health problem. There are 60 tenants here. They're newborn, they're teenagers. They're making crack, they're distributing crack.
So tonight's conversation.
No. I would like the board to hear when I complain to the people. When I complained to the people at the front desk yesterday, when I was paying my rent, the answer was, that's what you get for living in a neighborhood like this. And I said, excuse me, this is the Upper West Side. And then he said, not anymore.
So let me just
to live in a place, having immigrated to the United States and living with crack dealers when everybody's ignoring the situation. You know this hotel is illegal. Everybody's protecting this landlord. So I'm waiting for you to answer my email for the past 4 months.
So we'll have to stop you right there.
Thank you.
I want to make sure that somebody.
You wanna stop. You don't want to hear it. You want to think that you're helping. There are homeless people here illegally.
So
I'm smelling crack inside my apartment. I have to wake up tomorrow.
Stop you right there.
Thank you so much.
Sure to follow up with you.
Vaccine. I do not need the crack in my apartment and the heroin. The police is trying to help. Please do not defund the police. Thank you. Good night.
So just to be clear, our office is in communications with Miss Almeida. We speak to her on a regular basis. And I certainly have called in the situation to the Office of Special Enforcement on somewhat of a regular basis, because this Days Inn is a problem and the hotel owner is a problem. And the city is doing its job in trying to shut it down. I have immense sympathy for Miss Almeida, and she's bringing up really great points. No one should have to live in conditions like that, which is why my office, and I know you're in touch with the other elected officials, we're all trying really hard to address your issues. So I'm sorry they continue, but it is something that our office is addressing.
Thank you, Councilmember Rosenthal. If I could jump in real quickly. We also connected Ms. Almeida with the Goddard Riverside outreach folks, because this was a homeless outreach issue as well. So we're grateful for our elected partners. We're also grateful for the outreach center who has taken a role in this as well. Obviously, this is an issue that is kind of pernicious, and so it'll take a multi-pronged approach. But we and the community board, as well as our elected partners, have pushed the issue as far as we can, and we'll continue to do that.
Yeah, thank you, Mark.
Let's if we can have the contact information with Miss Almeida, just to make sure that we follow up with her. HHS can do that. If someone can share the contact information with Sheldon Fine and I.
Sure, no problem. Thank you, Catherine.
It's 9:40. So do we have any other questions or comments to do with the incredible forum that Rosa has organized? And do you have any final thoughts, Rosa?
No, I'm so happy. This was excellent. Everything was just amazing to hear, and I look forward to what's to come.
So, Rosa, we are so lucky. We are so fortunate to have you as a part of our community and on the board, and so thankful for you for doing this work. This would not have happened if it weren't for you. And so thank you so much. You did such an amazing job, right? Everybody agrees? Did a phenomenal job, and it's so much work. So thank you so much. We will definitely talk, we'll definitely think through ways to follow up and which items to follow up on, and we'll be in touch. You know, we'll follow up with all of the panelists that came. The last item on the agenda is just to talk about what's next. And next month, we are hosting a forum, and I just want to provide a description in case anyone has ideas on hate crimes. And just give me 1 second to pull it up. So we're providing a forum on how city agencies are addressing hate crimes, and importantly, how the community can address instances of hate, words or actions, and advocate for their own and others' rights. This is a response to recent events in our district and trends, and follows a resolution that HHS presented and that passed through full board on hate crimes. We are hoping to empower people to take action and know what to do, as well as what to expect in terms of possible remedies when instances occur, as well as improve understanding and climate in communities, including in digital settings. So those attending so far will be the hate crimes unit of the Manhattan DA's office, the mayor's office to end hate crimes, the New York City Commission on Human Rights, and hopefully the NYPD. So that's what's coming next. We would love it if anybody here on this call has ideas and wants to reach out to us. We'd love to hear them. Anything else? that folks have to share? Any comments, thoughts?
Motion to adjourn.
Motion to adjourn.
Thank you, Rosa. Very, very good.
Thank you.
It was outstanding.
Have a great night, everyone. Thank you.
Okay, thank you for staying on.
Thank
with
you,
us.
everyone. Have a good evening. Take care.
Okay.